Okay, well, I think we'll make a start today. Welcome everyone to Pediatric Teaching. Today I wanted to talk about soil-transmitted helminths in children. It's a very common problem and I think often under-recognised. We diagnose the child's pneumonia or their malaria or their diarrhoea, but we don't often diagnose their soil-transmitted helminths. And even though we see a lot of it, and it's probably as common as the other common conditions that we see like pneumonia and diarrhoea and malaria. Okay, so the World Health Organization has got a list of neglected tropical diseases, and this is their list. This is the WHO list of neglected tropical diseases, or NTDs, and I've just coloured in green the NTDs that are relatively common in Papua New Guinea and the Pacific Island countries. As you can see, there are some NTDs that are not seen in PNG, but there are many that are, and you'll recognise most of them. And soil-transmitted helminths is one of the neglected tropical diseases as designated by WHO. I'm going to try to explain today the different soil-transmitted helminths, but a simple summary of them, a very simple summary, and it's overly simplified, is that the host of these helminths, these parasites, can either be humans or dogs or cats or sometimes pigs, but of those that affect children, usually humans and dogs. They can invade in a number of ways through either the fecal oral route or through contaminated food that's contaminated with the eggs of helminths, or through skin penetration. They can affect a variety of different organs, often the small and the large intestine, or the skin, or the lungs, and very occasionally the brain. So the lungs and the brain are much less common, but the skin and the small and large intestines are the most common. And the treatment in general for helminths is albendazole. Some can only be treated by mebendazole or are better treated by mebendazole, and some are treated by ivermectin. Now, as I said, that's an oversimplification of soil-transmitted helminths. So I want to now make it a little bit more complicated so we can discuss the different types of soil-transmitted helminths. But you'll see as I talk about these, the host, the method of invasion, the organs affected, the clinical symptoms, and the treatment being a feature. So this is a table that I've made up that I hope describes this in more detail. All the soil-transmitted helminths that are common in Papua New Guinea, I've listed in the first column. So Ascaris lumbricoides, hookworm or Nicata americanus, cutaneous larva migrans, which is sometimes called dog hookworm, Ankylostoma brasiliensis, and then whipworm, Trichuris, trichiuria, Strongyloides stercoralis, and an unusual helminth, which is first described in Papua New Guinea, Strongyloides frulaborni kelly, which I'll explain in more detail. But they're the main helminths that you need to know about. And as I said, there's different hosts and different cycles. So some just have a human host and a human cycle. Some have a host that is a dog or a cat, etc. Some invade through the fecal oral route or contamination of food, and some only invade through skin penetration. And most infect the intestines, small or large, and some affect the airways or the lungs, and some cause specific abnormalities of the large intestine, such as rectal prolapse, and some affect the lungs and cause pulmonary edema or changes in the lungs, and occasionally cause a generalized systemic inflammation, and sometimes even affect the brain. So each of these helminths affect children in slightly different ways, and it's useful to know the life cycle and the host of each. So I'm going to go through each of these helminths and just talk about the life cycle so that you can distinguish between the various clinical syndromes that exist with helminths. This is Ascaris lumbricoides. So I've tried to draw the life cycle of this worm. And first of all, the adult worms for Ascaris live in the small intestine, and they can lay 20,000 eggs a day, a huge amount. The eggs are excreted in the feces, and then the unfertilized eggs pass in the stool. They can contaminate the ground or vegetables, or they can contaminate a garden. The eggs then embryonate, and they can then contaminate food. So there might be a bowl of lettuce or vegetables that are contaminated, and then they get eaten by a human host. The larvae then hatch in the duodenum. So they from the eggs they become larvae, and then the larva penetrates the duodenal mucosa, so the lining of the duodenum, and goes through the circulation. That is, if it penetrates the duodenal mucosa, it'll get in the veins, and the veins drain back through the inferior vena cava back to the heart, and then it goes to the lungs, and then from the lungs, from the blood vessels in the lungs, it can penetrate through the alveoli, and then the larva is in the airways, and then that causes cough, and the child coughs them up, and they get to the throat, and then they get swallowed again, and then the cycle continues. The children are most commonly affected because they often, because their fingers get contaminated with dirt, and they put them in their mouth, and the dirt is contaminated with the eggs of the Ascaris lumbricoides. So that's the life cycle of Ascaris lumbricoides. It's useful to know that, and to get an understanding of how the worm spreads through the system. So from the duodenum, absorbed into the veins, going back to the heart, and then from, of course, the right side of the heart to the lungs, the pulmonary vessels, and then through the pulmonary vessels into the alveoli, then up the tracheobronchial tree to the throat, and then they're swallowed again. So that's the life cycle, and it's useful to know that. Ascaris is a large round worm. It can be up to 15 or 30 centimeters long, and it's migratory, which just means it can migrate through the body. It can cause, on its travels, it can cause mechanical obstruction of the small bowel, and one clinical presentation is intussusception in a child who's got Ascaris with a bunch of worms, or it can cause appendicitis with obstruction of the appendiceal outflow tract. It can also obstruct other tubes or structures within the gastrointestinal tract, like the bile ducts or the pancreatic duct, the ampulla ovata or the bile ducts, and can cause jaundice or cholangitis or pancreatitis if it obstructs the pancreatic duct. It can also cause laryngeal obstruction if enough worms are coughed up, and the most classic presentation of Ascaris is what's called eosinophilic pneumonia, and this was described in about 1931 by a Swiss physician in Zurich, and this was Loeffler, and he described Loeffler's syndrome, which was eosinophilic pneumonia, transient consolidation on the chest X-ray, a lot of wheeze, and like asthma with eosinophilia, and some radiographic changes. It was it's an asthma-like illness with hypersensitivity reaction, IgE mediated, and so that's Loeffler's syndrome. But most children, they don't develop Loeffler's syndrome with asthma and wheeze, but they have malnutrition and distended abdomen and generalized edema because of hypoalbuminemia, because the worm can cause blood loss, but can also cause protein loss in the gastrointestinal tract. This was not the first description by Loeffler, but was one of the first large case reports of what Loeffler called transient pulmonary infiltration with eosinophilia, and the radiographic changes were characteristic in that when you take an X-ray of a patient with Loeffler's syndrome, the consolidation is typically at the peripheries of the lungs, and sometimes they don't stay in one place. They appear and disappear. So if you see transient pulmonary infiltrates in a child who's got eosinophilia, then think of Loeffler's syndrome. But there are many other manifestations of Ascaris lumbricoides. This is the chest X-ray of a patient who had Loeffler's syndrome with those peripheral consolidations that we see. Sometimes we might look at this and say it's pneumonia, or it's maybe even TB. It can look like TB, but it is transient. So if you do an X-ray a week later, then usually the radiographic consolidation will be in a different place. That's the characteristic feature. Whereas if you've got TB, it's going to be all in the one place. It won't change. It'll get worse or better or stay the same, but it won't move from one location in the lung to another. And eosinophilia is not usually a feature of other forms of pneumonia. The reason why children are more at risk of getting Ascaris lumbricoides is that they if contaminated feces are used on the garden to fertilize the garden, or just where vegetables are grown, where there's people using the garden as the toilet, mostly young children are affected, but some older children and adults can be affected as well. And it's particularly common where fruit and vegetables are not properly washed or peeled and cooked, which can remove the eggs from the fruit. The diagnosis is finding the eggs in the stool. This is what it looks like. These are what the eggs look like. And Professor Vince gave me a picture of all the worms that a child had passed. As you can see, masses of Ascaris worms. Remember, they're long worms, 15 to 30 centimeters long. The key is the eggs, finding the characteristic appearance of the eggs in the stool when you look by microscopy, just on a stool wet preparation, finding eosinophilia, and it's not a small amount. Usually these children have quite prominent eosinophilia. Usually the eosinophils are only up to about 3% of the total white cells in the blood, but usually when you've got Ascaris infection, it's somewhere between 10 and 30%, especially with Loeffler's syndrome. The treatment is albendazole or mebendazole. Albendazole is broad spectrum. I'll talk more about the anti-helminths a bit later, but albendazole is the treatment principally for Ascaris. The next one, so we talked about Ascaris lumbricoides. The second one is hookworm, and in Papua New Guinea, the most common cause of hookworm is Nicata americanus. Across the world, Ankylostoma duodenale is probably the most common form of hookworm, but it's not found in Papua New Guinea. It's Nicata americanus is the common cause of hookworm, and certainly half of the child population in many studies that have been done in the last 50 years have shown that about half the population is infected with hookworm, Nicata americanus. The transmission is skin penetration of larvae. So children with bare feet walk on dirt where there are larvae, and these tiny thread-like larvae penetrate. They've got a pointy tail and they penetrate through the skin of the feet. They travel through the subcutaneous venules and lymphatics, and again into the right heart, from the right side of the heart to the pulmonary arteries, to the pulmonary capillaries, and then they penetrate through the pulmonary capillaries into the alveoli, then up the tracheobronchial tree to the pharynx or the epiglottis, and then they're swallowed and then into the small intestine. So that's the life cycle of Nicata americanus. This is what it sort of looks like. So these tiny thread-like worms penetrate through the skin, and they pass through the lymphatics, the venules, into the veins, the right side of the heart, to the lungs. They're coughed up. They penetrate through the alveolar wall into the tracheobronchial tree, and they're coughed up, and they're swallowed and back into the intestines, and then passed in the stool as eggs again to embryonate in the soil and become larvae, which can penetrate through the skin again. So that's the life cycle of hookworm, Nicata americanus, and it's a very common cause of iron deficiency, gastrointestinal blood loss, and other gastrointestinal symptoms. Hookworm is, it's surprising how little blood is lost, but if that happens by one hookworm every day, and there are thousands of hookworm within the gastrointestinal tract, then you can lose a lot of blood each day, and over many months, a child can become anemic, and iron deficiency is the most common cause of presentation of hookworm. Children also have, so if you see a child who's got iron deficiency anemia with poor growth, often with edema because of hypoalbuminemia, they may also have a cramping abdominal pain. They may be colicky-like or irritable. They may have diarrhea. And by that stage, by the time that they've got well-established a large burden of hookworm, they often have some cognitive impairment or intellectual impairment, or they're having trouble learning at school just because they're undernourished and they're anemic. They may also have vitamin A deficiency because the hookworm consumes vitamin A to replicate. The hookworm consumes vitamin A. So what you have to do is to identify that clinical syndrome. Children with anemia and poor growth, and often moderate to severe malnutrition with gastrointestinal symptoms, and often some cognitive impairment with iron deficiency, the presence of iron deficiency on their full blood examination, and sometimes you'll see the ova in the stool. Then think of hookworm. Again, the treatment is albendazole or mebendazole plus iron. So replace the iron with ferrous sulfate. Usually I give vitamin C, that increases the iron absorption. Albendazole, and once you've given a good course of albendazole and you've started the child on iron, remember to tell them not to wear just have bare feet, run around in bare feet, but to wear shoes or runners, or not flip-flops. So it's something that will protect them from the penetration of the worm into the skin. They're just tiny little worms that can penetrate through the skin if you run around with in bare feet. Okay, the next, so we've talked about Ascaris lumbricoides, we've talked about Nicata americanus, the cause of hookworm, and this is what's called dog hookworm, and it's cutaneous larva migrans, or Ankylostoma brasilensis. Now, this is a little bit different. It only invades the skin. So unlike human hookworm, which goes around the body through the gastrointestinal tract and the lungs and up into the throat, dog hookworm only invades the skin. And this is the invasion of the worm through the skin in a child. The main host is the dog. They excrete the feces in the eggs. They hatch into rhabdotitiform larvae. The larva then penetrates through the skin in the same way as the human hookworm does. It penetrates through the skin through hair follicles or small cracks in the skin. So children should look after the skin of their feet by wearing shoes, basically, and by treating any skin breaches or cracks or anything like that. Anyway, if you wear bare feet, then the larva can penetrate through there. And all it does, as I said, it doesn't typically penetrate through the venules and the lymphatics and up through the right heart and the lungs. It doesn't do that, but it just burrows through the skin. And the larva penetrates, giving a real tingling and intense itch as the larva migrates through the skin. You can imagine this would be very itchy. And so that's cutaneous larva migrans. It's usually confined to the outer layers of the skin, so the epidermis. This is a worm within the skin. The larva can't penetrate through the basement membrane to reach the dermis, and therefore can't get into the blood vessels. But it infects usually the feet, the toes, anywhere. You can imagine if a child is walking around, then their feet and their toes will be most affected. If they kneel down on the ground, then their knees will be affected. If they're sitting on soil, then their buttocks might be affected. It's extremely itchy to have cutaneous larva migrans. The treatment is single dose albendazole or ivermectin. That's another treatment for it. It usually takes about a day or two to relieve the itch after you start treating with albendazole. And it can take about a week or so for the skin changes, these tracts to start healing, and to resolve. So we've talked about Ascaris lumbricoides. We've talked about Necata americanus, the human hookworm. We've talked about Ankylostoma brasilense, which is the dog hookworm. And now we're going to talk about Trichuris trichiuria, which is a little bit different too. This is called the whipworm. And similar to some of the other worms, this has a human life cycle. There's no other animal involved, but the eggs are excreted in the stool. The eggs live in the cecum or the colon in the large bowel. They're excreted in the stool, and usually they cause bloody diarrhea and anemia and wasting and rectal prolapse. That's the characteristic feature of Trichuris, is more large bowel symptoms. The eggs mature in the soil in the larvae, and the larvae hatch, and then the larvae can infect soil or vegetables, any garden. If there's contaminated soil, the eggs are then ingested by the human, and then they go to the small intestine and then hatch in the small intestine, and then go to the large intestine, where they cause most of the issues are in the large intestine. So if you think about Trichuris trichiuria, then think about large intestinal problems like dysentery and rectal prolapse. There's with Trichuris, unlike the hookworm, there's no cutaneous migration, and unlike Ascaris lumbricoides, there's no penetration into the blood or the lungs. It's all gastrointestinal and mostly large intestinal. So the adult worms are in the large bowel, in the cecum or the colon or the rectum, and this is a rectal prolapse in a small child from Trichuris trichiuria. It causes dysentery, usually without fever, usually just dysentery. Rectal prolapse is common because the worms infect the large bowel and the sigmoid. It causes iron deficiency anemia because of blood loss, bloody diarrhea, wasting, and eosinophilia. Again, quite high levels, more than 5 or 10% of all the white cells will be eosinophils. And if you do a direct fecal smear, you can see the Trichuris eggs on direct fecal smear. The treatment is ideally mebendazole, not albendazole. Albendazole is okay, but it's not as good as mebendazole. So 3 days of mebendazole is ideal. If you don't have that, then using albendazole is okay. All right, so we've talked about Ascaris lumbricoides. We've talked about human hookworm, Necata americanus. We've talked about Ankylostoma brasilense, the dog hookworm, and we've talked about Trichuris trichiuria, the whipworm. And now the last one is Strongyloides. Now, Strongyloides is another infestation that's relatively common in children in Papua New Guinea. At least a quarter of all children in previous studies have been infected. Strongyloides has a complex life cycle. It can have its own life cycle just in the soil. It can go from eggs to larvae to mature worms, and then laying the eggs in the soil. But it can also go through the dog host, and it's a bit like human hookworm, where there's a skin penetration phase. The skin can penetrate from the larvae that are in the soil, and they travel to the intestine again it goes deep within the skin and travels to the intestine by veins and lymphatics, and then can be coughed up into the lungs and cause lung disease, and also can have a complete life cycle within the intestine. So can have a life cycle that's both within the body, can be migratory, or it can have a life cycle that's in the stool, and it can keep circulating for a very long time. In fact, even during very elderly World War II veterans who spent time in tropical regions, even in their 80s and 90s, many elderly World War II veterans had Strongyloides, and sometimes they would when they became a bit more immune suppressed with age, they would manifest features of Strongyloides. usually in most people, it's quite a benign worm. It doesn't usually cause much illness, but if a patient's immunocompromised, then Strongyloides can cause illness. Most infections are trivial unless you're immune compromised. Other than that, there's an itchy eruption, often called larva currens, which means it's a fast migrating worm, as opposed to the dog hookworm, which is a slow migrating worm. Sometimes because it gets from the gastrointestinal tract into the lungs, it can cause cough and wheeze, and sometimes it can cause abdominal pain, diarrhea, and steatorrhea, or malabsorption, fat malabsorption, and typically causes weight loss too. When again, mostly in immune compromised adults. Sometimes you can get a hyperinfection syndrome in patients who are immune compromised, where you get a systemic inflammatory response with diarrhea and a paralytic ileus. And sometimes because it penetrates through the gastrointestinal tract mucosa, then you get gram-negative bacteremia and gram-negative septicemia. You can sometimes get effusions of the lungs. This is a patient who had Strongyloides hyperinfection with respiratory signs, cough and wheeze and dyspnea and hemoptysis, and sometimes it can even penetrate into the brain. But as I say, mostly that's in only immune compromised patients, whereas most of the other worms, Ascaris and human hookworm and Trichuris, can affect otherwise immune competent, immune normal hosts. The way to diagnose Strongyloides is, again, the clinical features, thinking about gastrointestinal features, sometimes thinking about wheeze and cough, chronic cough, and seeing eosinophilia on the blood film. And in children, particularly who have fat malabsorption, or if they're immune compromised, if they have HIV or some other form of immune compromise, then they're at risk of Strongyloides stercoralis infection. You can find in the stool, this is stool microscopy, looking for the motile larva or the eggs. These are the eggs and the larva. You can sometimes grow the larva in stool culture. The treatment is the same as most other worm infestations, a good dose of albendazole, in fact 3 doses for Strongyloides. And then the last Strongyloides I wanted to talk about was a Strongyloides, which is a little bit different because it's the only worm infestation that is common as a cause of vertical transmission. It can be transmitted from the mother to the baby through transplacental or breast milk transmission. And this is Strongyloides Fuller-Bornei Kellii, which is it causes this condition called swollen belly syndrome. And of course, there are many older children who can get swollen bellies with hookworm or Ascaris infections, but this occurred in quite young infants, and mostly in young infants. If you see swollen belly syndrome like this, then think of Strongyloides Fuller-Bornei Kellii, which is a Strongyloides infection that can be can be vertically transmitted. It was described by Professor Vince and other people in the late 70s in Canabia in Gulf Province, and later also in Madang. I wanted to just touch on the anti-helminth agents. I mean, I've talked throughout this talk about the use of albendazole and mebendazole. They're 2 of the thiabendazoles, and they were the second type of anti-helminths that were designed. The first type came in the 1960s, and they were plant fungicides, and then they were used as veterinary anti-helminths. But the first human drugs came when thiabendazole was first discovered in the sort of late 60s and early 70s. And then we had mebendazole, and now we have albendazole. There are some helminths that are better treated with mebendazole, but most are treated well with albendazole. The way albendazole and mebendazole act is that they act on the mitochondria of the worm, or the parasite, and so the parasite can't generate energy. You know, we all generate energy through the mitochondria of the cell, and the mebendazole and albendazole cause metabolic disruption of the parasite at different sites, mostly the mitochondria, and starve the parasite of energy, and so the parasite dies. Yeah. Albendazole is a highly effective anti-helminth drug, and most helminths are treated like hookworm and Ascaris are treated with a single dose, but for Strongyloides, it's best to give 3 days. So that's what justifies a general treatment for helminths as being 3 days treatment. The trouble is albendazole is less effective for Trichuris. So if you see a child who's got classic features of Trichuris, like large bowel disease with dysentery or rectal prolapse, that sort of thing, and you think it might be trichuria, then you're better off using albendazole for that. Use both albendazole and mebendazole, but remember, if you've got Trichuris with rectal prolapse, then you're better off using mebendazole. Sometimes people mix up the anti-protozoal drugs with the anti-helminth drugs, and I just wanted to make it clear that the two are quite different. So the anti-protozoal drugs like metronidazole are quite different to the anti-helminth drugs. The anti-protozoal drugs will affect protozoa like Giardia and Intermebia histolytica and Trichomonas and Gardnerella, but they will have some effect on Bacteroides fragilis, but they don't work on helminths. So when we are thinking about the use of metronidazole, we're thinking about it as an anti-protozoal drug or an anti-bacterial drug for anaerobes. But if we're treating helminths, then we need to be using albendazole or mebendazole or both. It should be said that I said how common soil transmitted helminths are, and they're neglected tropical diseases of the World Health Organization for a good reason. That is that they're tropical conditions that are linked to poverty and poor housing and poor sanitation and water supplies that are not good and poor food preparation and having no footwear. So all the features, I suppose, of people who live in poor circumstances, and they all have some things in common. They often cause iron deficiency and anemia, and they can lead to poor intellectual and developmental growth. So they can increase this sort of cycle of poverty in people who are intensely affected by them. There are programs of mass drug administration where albendazole is given to all children in communities, and that's part of standard treatment now. To any child who's got undernutrition should be treated with albendazole, because they quite likely would have a worm infestation. There are other mass drug administration programs giving out ivermectin to try to eliminate helminths as well. And then to tackle these types of conditions, there needs to be better public housing policies and sanitation and better water supplies and economic development in general, and education and better economic development leads to people buying shoes for their children, and then they won't get infected with such things. So what we've learned today, we've gone through Ascaris lumbricoides, we've gone through human hookworm, so Nicata americanus mostly. We've talked about cutaneous larva migrans, Ankylostoma brasilense. We've talked about whipworm or Trichuris, trichiuria, and we've talked about the two types of Strongyloides. Strongyloides stercoralis that causes malabsorption, stercoralis meaning malabsorption of fat, and Strongyloides fulibornae kellii, which causes swollen belly syndrome in young infants. So I hope that's helped you distinguish between the different types of helminths, and I'll send these slides around, so perhaps you can just go over them and try to learn them. You don't need to know a lot of detail, but I think if you know this much, that's all. So I'll just go back to this first slide about what we've talked about, this first one, where we aim to talk about all of these: Ascaris lumbricoides, Nicata americanus, Ankylostoma brasilense, Trichuris, trichiuria, Strongyloides stercoralis, and Strongyloides fulibornae. And I hope you can see how they're similar in many ways, but they're actually different in other ways. So that's all I wanted to say today. I'll stop there, and if you've got any questions, then please feel free to ask.